Hey everyone, this is the first video on wilderness first aid. We've already had 3 videos that talked about body systems. You've already seen me talking about the heart, the lungs, and the circulatory system. Now we're actually going to talk about how we apply that systemic knowledge to the care of a victim or someone who's ill. So let's get on with that. First thing I've got to point out is that the first step in providing care is actually making sure that you are all right. It's really easy in an emergency situation to get carried away and to just jump into the scenario as the hero. But you have to be super careful about that. So one point I'm going to make over and over in this class is that the first priority is to make sure that you're going to be safe. So before patient care starts, you need to be concerned about your care and the care for others with whom you might be responsible for. If you're out hiking with a group of 5 or 6 people and you run across somebody who needs emergency care, your first priority has got to be make sure that you're not piling on the injuries. You're not going to help that person out. And as a result of not planning that and not approaching that cautiously, you're going to end up with yourself or someone else injured. Having 3 people injured does not help the person that was initially injured. If you want to help the person that was initially injured, you have to first make sure that you're not going to pile on the injuries. That means our first priority always is safety. I know it's really tempting to just kind of like listen to me say that and say, yeah, that's something he's got to say. Move on and tell me about how to be cool and how to be a hero. Safety is your number one priority. I'm going to be hammering this in so many times. When I first started as an EMT, that was not something that was hammered into my brain. So back in the 80s and earlier than that, basically a lot of folks were trained as EMTs and paramedics, and they wanted to go out and be heroes. And there were a fair amount of injuries out there because folks were taking risks that they did not need to take. And again, getting yourself injured does not help the victim. So before you jump into caring for someone, you got to make sure, do I have my personal protective equipment on? What do I need to put on? I certainly need to put on gloves. Does this person look like they're ill in such a way where I need to put on a mask as well to make sure that I'm not possibly infected by whatever condition they've got? Do I need to think about some other kind of safety issues? Do I need boots, for example? Do I need to have some other safety precautions in place? So we'll often in emergency care talk about PPE, personal protective equipment, and BSI, body substance isolation, which just means the blood and other fluids and other things that might be coming out of the body of the victim. You have to make sure that you're protected from those and isolated from those particular harms. We also have to simply realize that there are threats out there. That's why potentially somebody is in need of your care. So if you're hiking along and you hear somebody screaming, help, help, it's likely, or at least possible, that the reason they need help is because there's a hazard there. Making yourself a victim of that hazard doesn't help them. So you really need to think about what the scenario is. What we like to say in emergency care is what the mechanism of injury is, or what the nature of illness is. And you want to think about that initially to make sure that you're not going to fall prey to that same mechanism. So you're hiking, you run across a campsite of somebody and you see them laying there and they seem like they're partially conscious. Okay, you definitely want to provide them with care, but you also want to ask yourself, does this person look like perhaps they've got an illness that might be contagious? Are they coughing? Is there sputum? Is there a lot of blood? Do they have a mechanism of his injury that might indicate some kind of problem? Is there a half-fallen tree dangling over their head that they were the victim of? Is there a rock slide and are there still loose rocks around? Especially in a wilderness scenario, there's all kinds of possibilities. Whatever hurt them could hurt you as well. So you want to protect yourself from that. And by the way, even not in a wilderness scenario, that is still a real issue. You might be walking through campus and you say somebody, I don't know, lying on the floor of a classroom through a window, and you say, hey, I got to go help that person. So you run into that classroom. And the reason the person's lying on the floor is because they were electrocuted by a loose wire that you just stepped right on and got yourself electrocuted as well. Or the reason that they're laying on the floor is because a light fixture fell from the ceiling and that light fixture has broken glass all over the floor and now you're cut up as well. In other words, be aware of the fact that if somebody is injured, there's a reason they're injured, and you want to make sure that that same injury doesn't happen to you. And in a wilderness scenario, that could also be wildlife. So if somebody is passed out on the side of a trail, is it a snake bite? And if it is that snake still around? Is it a spider bite? And are they laying near maybe, I don't know, an old rotted piece of trunk that has some black widows in it? And do I want to get away from that scene and pull them away from that scene possibly? Or if they are laying on the ground screaming with severe trauma, is that a bear attack? And I want to make sure that I'm protected from that bear attack before I go running to that person that seems to be bear bait. So make sure that your first priority is always your own safety and the safety of your team. If you're the one that's trained in emergency care, then you're the one that needs to take command of the situation, which means you might have 3 or 4 other folks that are hiking along with you, and they might sort of get excited by this, right? Everybody's adrenaline's running. So they see somebody who's got an arm ripped off 30 feet off the side of the trail, and they're running toward that person. Hey, this guy's got an arm ripped off. I need to help him. And you've got to be wise enough to say, whoa, 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 hang back. Let me take a look at the scene here and see what's going on, because you running into a grizzly bear is not going to help that guy out at all. So basically, there's some things we want to evaluate and be cautious of before we start running in to take care of a patient. Doesn't mean we don't want to make that patient a high priority. It just means that the way to make that patient a high priority is to make sure that your safety is the highest priority. You're going to notice in the text, they say, check, call, care. Check the patient, call for assistance, and then provide care in that order. The first step is to check the patient. So I want to talk about that a little bit. But first, I also want to highlight that sequence. It's not check, care, call. It's check, call, care. Now, just about anywhere you hike in the wilderness, anywhere around the world, you've probably got some mechanism of communication. Cellular phone, maybe a satellite phone. Maybe you need to hike up to a local peak in order to get a good cell phone connection. You want to plan for that as well. You want to make sure that that communication happens, because often the thing that's going to be the difference between life and death for an injured person is providing them with care in a timely manner. So check the person. If they need care, call for that care, which may mean take somebody from your group and say, hey, go hike up to that peak right there as fast as you can and make a call to EMS. And then provide care. But don't get so wrapped up in the care that you forget about the fact that you need somebody besides you to be caring for that person. Not that you're not able to care for somebody, that if we're talking about a serious injury, it's going to have to be more than one first aid trained bystander. Okay, so let's talk about the check scenario. You're going to check the scene, you're going to check resources, and you're going to check the victim, which means, as I talked about before, check the scene. Was this a bear attack? Is that bear still around? Was this a fallen tree branch? Are there other branches that are going to fall on me? Is this a rock slide? Is the terrain stable? Is this a sinkhole? Am I going to fall in just the way that fella fell in? What resources are available as well? How many folks are there in your team? What kind of training do they have? What kind of first aid training do you have, et cetera? This should be running through your head because, again, you've got to decide how aggressively you want to call for outside resources. If somebody's just got, their thumb a little hurt, maybe you can handle it and hike them out. Okay, fine. If somebody needs real emergency care with a helicopter evacuation, you need to decide that right away. Seconds are going to count. And then evaluate the victim more closely. So what kinds of things? Well, right here, it shows you the sorts of things you need to be concerned about. One, as I've described, establish control of the situation and recognize the nature of the emergency. Recognize the emergency is always the first step. And I can't tell you how many times people don't do that. And sometimes, not sometimes, always, it's not clear. So I remember I was one time hiking with my wife, and we were like on the edge of a lake, hiking along the lake. It's pretty quiet. And I hear, help, help. And I turn to my wife, I'm like, is that for real? Do you hear that? And she's like, hear what? And I said, I hear somebody yelling. And sure enough, I look out in the lake and there's like a boat floating by, a kayak that's maybe, I don't know, 150 feet, 200 feet from shore. And some fella is like holding on to the side of it. And there's another young person in another kayak floating along by, and they're floating along and he's yelling, help, help. And I'm kind of thinking like, are they just goofing off? Like, I mean, he's got a kayak. What could possibly be the problem, right? Paddle the shore if you don't like it out there. So I'm like, is that guy for real? And I'm, yelling out to him, hey, what's going on? He says, help me, help me. And that's when like, oh shit. Okay, fine. So I got to do it. So strip down to my boxer shorts and go in. And it turns out this is some guy who decided he was just going to go kayaking with his young nephew, didn't know how to kayak, didn't know how to use a paddle, didn't know nothing, lost balance, fell out of the kayak, and was being pulled away, and had already been like a mile downriver from where he intended to be as the water was just pulling him away. And evidently somebody else upriver some had heard him too, but didn't know what to do. So there was already like a helicopter coming in. I swim out there and of course, grab the kayak, get in the kayak, get him on the back of the kayak, because it's always better if you can to take somebody out of the water without doing the whole rescue swimming thing. If you can reach and grab them and pull them out, or a long branch or stick and pull them out that way without actually getting in, which I couldn't do, is too far out. That's always better. But if you can't do those, then paddle out there or get a boat out there is always better than swimming out there. Things get messy when you're in the water with a victim. Anyways, pull him back to shore and, give him a little bit of care and whatever, and then go back and get his nephew and whatnot, and everything worked out fine. But my point is, I was like genuinely like, is this really an emergency? I mean, the guy's only 150, 200 feet offshore. This doesn't seem like an emergency to me as an experienced boater. But to him, it was an emergency and he needed help. And luckily for him, I guess, I recognized that, oh yeah, this is an emergency and you need care. Otherwise, he might have gotten a few more miles down water before the helicopter, I guess, eventually picked him up. We were able to wave off the helicopter and tell him to go away because it was no big deal. But my point is, what may not seem serious to you could be serious to someone else who's in way over their head. And what may not seem like an emergency may turn out to be an emergency upon closer evaluation. So you want to recognize the potential for an emergency and take it seriously as soon as you do that. So that's step number one. Step two, check the scene. We talked about this before. Check that mechanism of injury, check the nature of the illness, make sure that you're safe, put on your PPE to make sure that you're going to be protected. You getting sick is not going to help the person that's sick. And then for other members of your group, make sure that's the same thing. You've got folks with you that may not be first aid trained. If they start running to this person, you might have to say, wait. That person looks sick. He's vomiting profusely. Let's get some mask on, or at least bandanas wrapped around our face or whatever it is. Hopefully you got a first aid kit with a couple of PPE mask and some gloves. Let's get those on before we start dealing with this person, because that's a lot of body substances that we need to be protected from. So we're going to try to prevent transmission of disease. The next thing we want to do is we want to make sure we get consent from the person. So if it's somebody who's kind of feeling sick and they're kind of, half in and out, or has got an injury, you want to say, hey, my name is whatever, in my case, Patrick, and I'm trained in first aid. Can I help you out? Or do you need some help? Make sure they're okay with that. If they say no, and they appear to be of sound mind and capable of reasonable, deliberate thought, you don't have a legal right to help them. If, on the other hand, they don't seem capable of legal, deliberative thought, or if they're unconscious, then you may have consent, but you want to make sure you get consent. And ideally, that consent is deliberate, informed consent from the person. So you run up to them or walk up to them and you say, hey, my name is Patrick. I'm trained in first aid. Would you like some help? And they say yes. Do you know what they call it when somebody does, say, life-saving CPR, and they don't have that consent? It's called assault and battery. It's illegal because you may have somebody who's just sleeping. And so jumping on somebody's chest and starting to pump on their chest, not really a great way to wake up. So we want to make sure they have that consent. Basically, then, if you watched, looked at the textbook, you tap on the person, maybe you shake them a little, you say, hey, are you okay? You're checking to make sure that they are fully conscious first, their level of consciousness, and you're checking for that consent. Once you've checked for the consent and the level of consciousness, you can then move on. If they're not conscious, if you say, hey, are you okay? And there's no response, you have what's called implied consent. That is to say, by law, it is safe to assume that a reasonable person would want your care if they're unconscious. So you can get implied consent in that case. And of course, as another caveat, if it's a minor, you ideally want the parent or guardian's consent. If the parent or guardian isn't around or is unconscious, again, you can make a reasonable presumption. A reasonable person would want me to help their child if they are unconscious or unable to give consent. That could be an implied consent as well. But either way, you want to make sure that you're not, grabbing a person who's just sleeping and starting CPR on them. Again, as you then approach the person, check for the nature of illness, the mechanism of injury, make sure you've got some sense of, what hurt them, what the situation is. If necessary, move the patient out of an area of harm. In a second, I'm going to be talking about spinal cord injuries. And in fact, you've probably heard, if you've done any CPR, that you don't want to move somebody because they could have a spinal cord injury. Granted, that's true. But if they are in a rock slide area, being buried by rocks is worse than a spinal cord injury. So there are situations when you need to emergently move somebody out of a dangerous situation. And that happens not unfrequently in the wild. If somebody's injured in the wilderness, that risk is still around. So you don't want to put yourself in that risk, and you don't want to keep them in that risk. So we'll talk about and show when we meet in person how to move somebody safely out of such a scenario with minimizing the potential harm to their spine. It is true that spinal isolation, some way of stabilizing the spine so as not to cause further harm, is an important characteristic of first aid. But more important than that is not allowing further harm in other ways. So we're going to do that. We're going to assess the situation. We're going to identify available resources. Do I have a first aid kit? Do I have a means of getting them out? Do I have a means of communication? Do we have good cell access? Do I have a satellite phone? Do I have ways of reaching out and getting help? What other trained responders are available to me? Are there other people in my crew that can help me because they've had first aid training or some other kind of training? All that's got to run through your head so that you can put together at least a preliminary plan of how you're going to care for this person. The other thing I should say is when you're helping, or I shouldn't say this, when you're giving instructions to folks, now you're the one that's going to be trained in first aid. So it's likely that with you're with a group and somebody in your group is hurt, or you run across somebody who's hurt, you're going to be the one in charge. You're going to be one that effectively takes command of that situation. That means you need to give instructions that are absolutely clear and absolutely accountable. The common story in EMS is that somebody goes down with a heart attack and people say, oh my goodness, call 911, call 911. And everybody in the group assumes somebody else called 911. Nobody actually calls 911. So it's much more effective to say, John, call 911, or John, get up back on the trail about half a mile where we had good cell reception and call 911. And then it's great if you can give them a little more instruction, because basically somebody's going to be panicked and then they're going to call 911 and say, we're out hiking and there's somebody and I don't know what's going on. Better to say, call 911. Tell them we're on whatever, the Pitchman Trail, about 2 miles away from Echo Lake. And we've got somebody who seems to be in cardiac arrest. So that person has a script. They know what to say, because you, as the trained person, are less likely to panic than they are. So make sure that the correct information is going out. And in an ideal scenario, you'll have cell reception or satellite phone reception or something. So once you've assessed the victim, you'll be able to give more information to the EMS. Okay, what's the first thing you're going to do when you reach the person after you check them for responsiveness and you find out, hey, they're not responding? Well, we're going to talk about, when we get together, the ABCs, which is the basics of emergency care, right? Airway, breathing, circulation. But I'm going to add to that a little bit. I'm going to call it the XABCDEs. X stands for exsanguination, which is bleeding out. So yeah, first things we want to do is ABC, airway, breathing, circulation, except if the guy's missing a leg and is bleeding out profusely, in which case you can do all the CPR you want, but it's not putting the leg back on and it's not going to bring that person back to life. You got to stop the bleeding first. So the first thing you're going to do is a quick scan, like a 15-second scan of the victim, and find and see if there's any major bleed or other life threat. Is there a log on their chest that is crushing them? That would be kind of obvious, but perhaps a serious cut on the foot. Somebody might be passed out. You might look at them and say, oh, they're not breathing. There's no pulse. I should begin CPR. And you never notice that the reason they passed out is because they put an axe through their foot and they bled out. And so the first thing you really need to do is put a tourniquet on that, because until you stop the bleeding, you've got no hopes of resuscitating them, right? So that quick check, that 5 to 15-second check to make sure there's no life-threatening bleeding on the person or other serious life threats. Then it's the ABCs, and we'll go through this in more detail in person for sure, both in the CPR class and then in our weekend together. But that means the airway. So opening the airway, making sure that you got a clear airway. Is their mouth filled with vomit? Is their mouth filled with their dentures, some broken teeth, something else that might be inhibiting their ability to breathe? Then, are they breathing adequately? So quickly check, is the chest rising and falling, or do you get some indications that the person's breathing? Maybe you can hear air moving in and out of their mouth. And then circulation. That's where you're going to want to check their pulse, and we'll talk about how to do this in person and see if their heart is beating, if they're getting some circulation. There's the key ABCs. I'm not going to do too much of that on this video. These videos are just big conceptual kinds of things, but in person, we're going to spend a fair amount of time on X, A, B, C, D, E. Once you've done those three, you also want to look into possible disabilities, other kinds of injuries or illnesses that could be serious and create serious problems for them. In the wilderness, these matter greatly. Do they have a grossly angulated leg that is clearly problematic and will need to be resolved? Or is there some other reason that they might be in respiratory distress, etc.? Basically, again, an evaluation of what are the main problems and threats to this person. And then lastly, exposures. So if you're, brought this person back and you check their ABCs and those all look good, you might also think about, oh yeah, but this person's soaking wet and it's 12 degrees out. So there's possible hypothermia here, and I need to protect for that as well. Let me get these wet clothes off. Let me get them in a dry blanket and try to see if I can rewarm them. And we'll talk in greater detail about that. But my point here is, even at this initial phase, ABCs are key, but it's not just ABCs. Life-threatening bleeding and other life threats, then airway, breathing, circulation, then possibly disabilities and exposure threats. That is your primary or initial assessment. Basically, you've just arrived at the person, you've evaluated the mechanism of injury. Now you're going to do the X, A, B, C, D, E. When you're doing this, isn't that an awesome picture? When you're doing this, there's a few things you have to keep in mind. First, your goal in the primary assessment is address the threats to life. Just don't get distracted with, why is this happening? Or I wonder if this person has this illness or whatnot. Threats to life first. Later, you will deal with things like, oh, is this person perhaps a diabetic? And is that an issue here? Is there a blood sugar issue? Or did this person get hit on the head? Is that possibly what's going on? Or maybe this person's dehydrated. But initially, you just got to deal with the threats to life. Once that person seems stable, once you've got them to the point where it doesn't feel like death is imminent, then you can think about, is this dehydration? Is this diabetes? Is this hypoglycemia? What's the issue here? So determining the nature of the illness or injury can wait until you've stabilized the patient. And don't let yourself get distracted. I mean, look at that. That is pretty nasty. It'd be easy to come up to somebody, see that, and start wrapping that up. Oh my God, I've got to deal with that. But look at that. It's not bleeding. And in fact, often injuries like that won't be bleeding. That is not a threat to life. But the shock that might have started, the cardiac arrest that might have catalyzed, those could be a threat, an immediate threat, I should say, to life. So don't get distracted with the obvious injury. Always remember, XABC, then deal with things like this. That clearly needs to be dealt with, but it may not be the first thing that needs to be dealt with. So our primary assessment is looking at those threats to life based on life-threatening bleeding and airway, breathing, circulation. as well as possible environmental exposures and disabilities. Once you've done that, if the patient is conscious or if there's other people around that know that patient or victim, you might want to try to get a basic history. And at this point, you're thinking, Hase, what the hell? I am not running a clinic here. Are you saying I should give them a form and have them check off? Did you ever have these illnesses as a child? What vaccinations have you had, et cetera, et cetera? No. But I'm saying you need a basic history of the situation and their medical condition so that you can give them proper care, but also because that may be the only information that the physician has. So realize you may run across somebody, I don't know, a mile or two into the back country, and you're going to be able to hike them out in a stretcher, so that's all well and good. But by the time you get them out, they've passed out. And when they get to the hospital, obvious questions that the physician's going to have before they do something like emergency surgery is, does this person have any allergies? Are they on any medications? When was the last time they ate? Those issues might be really important in determining whether or not or how you're going to approach care for this emergency. So you need to answer those questions if you can. So if you've got a patient that's conscious, once you've provided care and stabilized the patient for emergent life threats, ask some questions and get some basic history from them. Or if they're there with their husband, wife, boyfriend, girlfriend, significant other, best friend, whatever, ask that person some questions to get a sense of things like what happened. Do you know anything about this person's past medical history, et cetera, et cetera? These can be critically important in all kinds of ways. Later in class, I'm going to talk about, for example, seizures. Understanding what caused a seizure can be really important. And information on what the seizure looked like can be key for that, because a seizure often looks a lot like just fainting, what we call syncope. But those two are really, really different things. So if you see somebody having a seizure, it would be great if you could provide that information to the physician, because the physician is going to get somebody an hour or two after a seizure and wonder, like, okay, was this a seizure? What kind of seizure was this? What caused the seizure? Or maybe this was just passing out. Do I really know? It'd be great if you could say, okay, the person had jerky movements for 3 minutes, approximately 30 or 40 jerks, stiffening of the upper arms, eyes were darting back and forth, et cetera. So the physician can say, okay, I'm getting a sense of what the problem is. So you providing some history matters too. Okay. When providing history, there's a couple of mnemonic tips that are used that are really actually very helpful. One is sample, and this one's in your text. Sample is a mnemonic tip that helps you remember what to ask for when you're getting a basic history in this way. So you run across somebody who's at a campsite and they've thrown up, they vomited a few times, they're not looking very good, pretty pale, diaphoretic, that means sweaty. And you're thinking, okay, this doesn't look good. You need information because you're going to help this person get out, maybe even rig up some kind of stretcher and if they can't walk on their own and get them out of the backcountry. But the thing is, they may not be fully conscious or fully able to interact with folks by the time you get them out. So it'd be great if you get some questions answered. Sample allows you to do that. S in sample is symptoms and signs. What are the key symptoms and signs here? And often what we say in medicine is, what's the patient's chief complaint? That's also really key here. So ask the patient, what's going on? What seems wrong? And then in their own words, try to remember what they say, because that's going to be really helpful for the physician when they actually provide care. So if the patient says, it feels like my abdomen is tearing up, it feels like a ripping pain, that is really key, and that will tell a physician a lot. If instead, it's kind of like, oh, my stomach's kind of bothering me, I don't know what that means. So you want to get some detail, you want to get some description from them as a chief complaint. So S is symptoms and signs. Signs might be things like, are they sweating a lot? Are they not sweating at all? Is their skin clammy, etc. The distinction in medicine between signs and symptoms is stuff the patient tells you, and signs are things that you can see for yourself. Not too critical, but important to think about. A stands for allergies. This one's actually really important. I know you're not really concerned about like, hey, do you have hay fever? But other kinds of allergies, like are you allergic to penicillin? Are there things that give you really bad reactions? Not only could this current illness be the result of those allergies, but also when we get you back to the hospital, it'd be really good if we knew what you were allergic to. So any allergies, and in addition to that, any medications. That's what the M in sample is. Any medications you're on. Are you currently on any medications? This could make a huge difference. If you run across somebody who, for example, is having a heart attack, it'll be really important to know what medications they may be on, because that may limit or shape the medical options available when they get to the hospital or when they get to an ambulance. P stands for past, or if you'd like, pertinent medical history. So, have you had a heart attack before? Does this feel like the heart attack you had before? You seem to be having trouble breathing. Do you have trouble breathing often? Do you have other issues like this? This can actually be key. So if you got somebody who says, I have a really bad chest pain, and you say, okay, have you had situations like this before? Well, I had a heart attack a year ago. Does this feel like the heart attack you had a year ago? And if they say, no, not at all, that's really helpful to a physician. On the other hand, if they say, yeah, it feels just like the heart attack I had last year, that also is really helpful to a physician. So you want to have answers related to the pertinent medical history of that person. You also want to have some answers for L, which is last oral intake and last output. In other words, when was the last time they ate and drank something? This matters first in case they need surgery for whatever situation is going on, but also to help you and others identify what the possible problem is, especially in the wilderness. When did you eat last? Well, I had some of those berries on the side of the trail 20 minutes ago. Oh, really? Those bright red berries that looked really poisonous? Okay, good to know. But also, whether or not surgery is a possibility and how to approach surgery, it'll matter greatly when they last ate and when they last drank. In addition to that, maybe when they last pooped and when they last urinated. And that will help you also identify things like maybe hypoglycemia, certainly hyperglycemia, but also maybe things like whether they're dehydrated. So when you ask them, when was the last time you peed? Yesterday morning? Oh, wow, okay. It may be that you're not drinking enough. So that may indicate to you that, if this person's able to swallow, you might want to get some fluid into them, right? And then events leading up to the situation. So that's the E in sample. And basically what you're asking is, tell me a little bit about what happened here. So, oh, your abdomen's hurting. When did your abdomen start hurting? And what was the situation? Or, oh, your arm seems to be detached from your body. Can you tell me about exactly how that happened? So that's the sample history. In addition to that, if you have time, not in your textbook, is OPQRST. And OPQRST is pretty easy to remember because it comes in alphabetical order. And that is a way of addressing any pain in the person. So if somebody has abdominal pain, or if they have pain from some kind of trauma, whatever it is, you can ask questions related to OPQRST. And the OPQRST stands for O, which is onset. What caused this to happen? When did this start? Now, if somebody's arm is severed, okay, I think this probably started when I put the machete through my arm. But if somebody has chest pain, when did the chest pain start? That could be really important. It started when I was hiking up this really steep hill. That is really key and important for a provider to know that, oh, the chest pain started when they physically exerted themselves. That may make all the difference in their diagnosis. P stands for provocation or palliation, which means what makes it better or worse? You've got chest pain. Is there anything that makes it better or worse? It's a little better when I relax and lay down, and it's a lot worse when I try to stand back up. That's super helpful. Q is the quality of the pain. Describe the pain. And here, it's best if you not lead them on with things like, hey, is this a sharp pain? Is this a dull pain, etc.? But describe the pain to me. And for example, if they have an abdominal pain and they say it's a tearing pain, that might be something we call an aortic aneurysm. That is life-threatening and really important. If they instead say it feels like a dull pressure, that's a whole different thing and maybe not as urgent. So it's nice if they can, in their own words, describe the nature of the pain. And then R stands for radiation. What that means is the pain radiating in any direction? So, for example, if it's a heart attack, typically it will radiate up to the upper left shoulder. And that is a nice clue, but it's also true for other things. And it will allow a doctor to also find possibilities of referred pain, where the injury is one place, but the pain is felt somewhere else. So if they have pain in their hips, you can see, okay, is it just in your hips, or does it feel like it's moving around a little? Oh, it's in my hips, and it flashes all the way down my left leg. That's really helpful. And again, you might say, do I really need to have, play 20 questions with somebody when I'm in the wilderness? You may be the last person that can have a conversation with this person before they lose consciousness. So yeah, the more information you get from this person, the better off. That's R. S is severity of the pain. And the usual way to do this is to say, on a scale of 1 to 10, where 1 is no pain at all and 10 is the worst pain you could possibly imagine, where does this lie? And the nice thing about that is, even if they don't lose consciousness, it allows everybody to get a sense of whether things are getting better or worse. In other words, if you're hiking this person out for a few hours and then they're in the ambulance for another hour before they get to the emergency room, it's tough to know if things are getting better or worse. They'll say, my leg hurts, my leg still hurts, and my leg still hurts throughout the whole 3-hour transport. But if you start out by saying, scale of 1 to 10, how bad does this hurt? And they say a 6. Then you ask them a little later and they say, oh, that's an 8. And you ask them a little later and they say it's a 10. That tells you a lot. On the other hand, if you ask them and they say it's an 8, and then maybe you provide a little traction, or you wrap it up, or you stop some bleeding, and how is it now? And they say, oh, it's a 5. That's working out for you. So now you got some sense of whether things are better or worse. So that's a really nice trick. And then last is time, T, and the time is just when this started. And for some things, like, for example, the example I gave before of a seizure, it's really important to know when it starts, or possibly for a stroke. And you might say, this is a class on wilderness medicine. I want to talk about like trees falling on people's heads and surviving rock slides. I don't want to talk about like a stroke. Yeah, well, people out in the wilderness also have strokes. And for a stroke, knowing exactly when it happened is vital to their survival. So it may not seem like it's that important to say, okay, when was the last time, maybe they're asking their friends, when was the last time you saw them acting normally? That could be the difference between life and death for that patient. If they say, he was acting normally at 2 o'clock and now it's 2:45, that's way better prognosis than he's been acting off for the past 5 hours. So you want to ask those questions, OPQRST. Once you've done that, you can go on to the secondary assessment. So what we've done here is we've done the primary assessment, which is saving their life, making sure they're stable. We did a history. And then we're going to do a secondary assessment. And the secondary assessment is basically now taking a little more time and evaluating where they're at and what other possible injuries there are to the person. If it's a trauma case or even an illness case in the wilderness, we're going to do a head-to-toe exam of them. So certainly before we start moving them, we want to make sure we didn't miss anything. Again, you might have treated them and you found a bleed, and now you've stopped the bleed and they're kind of semi-conscious, and you figure out, awesome. Are you sure? Have you looked through the entire body to make sure there's another bleed you haven't missed? Are you sure that that bleed is the only problem? Are you sure that bleed is what's causing them to lose consciousness? This is where you get to be sure. You get to check them from head to toe. So we're going to do this in class, so you'll get a chance to do this hands-on, but we're literally going to start at the top of the head, move our way down, ears, mouth, nose, eyes, neck, shoulders, chest, abdomen, evaluating them all the way through. In your textbook, it talks about dots, deformities, open injuries, tenderness, swelling. Basically, we're looking for any of those anywhere in the body. If you ever get trained in emergency medicine, you'll learn DCAP BTLS, which is basically the same thing, but a broader scope. That stands for deformities, contusions, which are bruises, abrasions, which are like rips and rashes, penetrations, like you know what a penetration is, burns, tenderness, lacerations, and swelling. Okay, you can remember that if you'd like. I do want you to remember dots, but basically what you have to remember is I'm looking through the whole body and looking for something that shouldn't be there. I'm looking for a tear in the skin. I'm looking for bruising. I'm looking for swelling. I'm looking for deformities. I'm looking for something that is not present in a person who's not injured, whatever it is. So don't try to memorize, DCAP BTLS, and then you forget that B stands for burns. And so like you're checking the person out, you're like, oh, there's a big burn in the back, but that's not part of DOTS. So I guess the burn's okay. There's a burn there. That's obviously a problem. So we're basically looking through for any kinds of problems. And I'm going to talk about in class what that looks like. And actually, we'll have another lecture that's going to talk about trauma that's going to look at some of that as well. But basically, we're going to check them from top to bottom. We're also then going to check for CSM, which is circulation, sensation, and motion, which is sometimes called PMS, pulse, motor, and sensation. But whatever you want to call it, what it really means is we're going to check the fingers and we're going to check the toes, we're going to check at the feet, and we're going to check at the hands to make sure that we're getting decent circulation. So that could be, first off, what's the skin look like? Is it pale and clammy, which indicates bad circulation? Is it red? Is the person sweating, what we call diaphoretic? But then also in the peripheries, in the hands, in the feet, do they have sensation? You can ask them if they're conscious, do you feel numbness? Do you feel it? What you might do is actually grab one of their fingers and say, hey, which finger am I holding? So not just, do you feel this, but rather, which of your fingers am I holding right now? And then you might say, okay, squeeze my hand. Squeeze my hand hard. And if a hard squeeze feels like not much, feels like butter, maybe there's some problem there. That will help you know which body parts to isolate, how urgent the situation is, and what kind of other care you might need to provide for the person. So we'll talk about that in person too, how to do that kind of evaluation. So we're checking the skin for color, temperature, and clarity. Are there any parts of the body that are febrile, that are hot, that are maybe swollen, that maybe are red? Or is it the opposite? Are they clammy? Are they pale? Is it white? All of these really matter, and we need to be on top of that. We're also going to check for responsiveness now with a little more detail. So before, we just basically checked for responsiveness by saying, hey, are you all right? And if the person didn't respond, okay, they didn't respond. But it'll be helpful now, especially as we get on the phone to EMS or a medical provider, to give a more concrete description of what the situation is in terms of the responsiveness. So we use what's called the AVPU scale. You'll notice there it's AVPU. We're going to start with the U. The U is unresponsive. So U is, you tap them, are you all right? No response. Then you might go to the next step. Okay, they're not responding to just the tapping. So I'm going to try a little bit of stimuli, maybe grab them here in the trap, squeeze a little bit. Do they respond to that? And they don't respond and wake up. They may just respond and be going, ah. Okay, they're responsive to pain. So now you know that they're responsive to pain. That's helpful. Another way to provide a little bit of modest pain besides squeezing the trap, which is the one I like, by the way, is a sternal rub. So take your fingers, just doing a little abrasive rub on their chest. Either one of those might prompt a response. And the response might just be a little twinge, or it might be that they push you away or whatever. That's good to know. And that'll be really helpful for the medical providers to know, especially if it changes. So you might say, I'll leave that for the paramedics to check once we get to the ambulance. It might change by the time the paramedics come, and it might really be helpful to know that, hey, an hour ago, the person was responsive to pain. Now they're no longer responsive to pain. So you want to check that. So are they responsive to pain? Something like that. If they're not responsive to pain, okay. Are they responsive to voice? So before you check for pain, you already checked, right? You said, hey, are you okay? And they didn't respond to that. But if they did respond to that, that's good to know. Maybe they were unconscious. And when you then tapped them, you kind of brought them out of it a little bit, but they're still only kind of part of out of it. So now you need a more concrete sense of exactly how alert they are. So you can ask questions like, what's your name? My name's Patrick. I'm a first aid responder. I'm here to help you. Is that okay? Yeah. What's your name? I don't know. Okay, good to know. So in that case, that person is perhaps partially alert, but not very alert. If the person does know their name, they know who they are, then you want to ask, okay, where are you? Do you know where you are? And if the person says, yeah, my name is John Smith, and I'm on the whatever, Black Ball Trail. Okay, So far, the person is oriented times 2. They know their name, so they know who they are, and they know where they are, who and where. Then you might ask the next question, when? Okay, John, what day is today? Don't ask them, by the way, the date, because nobody knows the date. I can tell you from experience, if you say, what day of the month is it? They'll be like, I have no idea. And if they do know, they'll say the 28th, and I'll be like, okay, is it the 28th? I'm not sure. I thought it was the 25th. So don't ask a concrete question like that, but you might just sort of say, what day of the week is it? Or what month is it? Something like that, to get some orientation to know when. And then you can ask them about the events. What happened here? And if they say, my name is John Smith, and I'm on the Black Ball Trail, and I tripped over a rock, and I fell, and it's Sunday, and then I passed out, and that's the last I remembered. Okay, right now they are alert and oriented. So we actually sometimes say AO times 4 or AO times 3. And we're not expecting you to know exactly that vocabulary, but that's what that means. And getting some sense of that, going through the AVPU scale and getting a sense of, are they fully alert? And times what? 1, 2, 3, 4. Are they alert to who, where, when, and how? Or are they just alert to who and where? It's helpful, again, for a physician to know, have they lost some memory of the injury? So if the person sort of says, yeah, I know who I am and I know what trail I'm on, but I don't know anything else, I have no idea why I'm laying here, that's very helpful. And again, if they don't respond, then are they responsive to verbal stimuli? When you yell at them, do they at least moan or groan? And if they don't, when you pinch them or provide some kind of physical stimulus, do they respond to that? And if they don't, then they're totally unresponsive. And you want to you want to give that information to EMS. Remember, in most situations now, even if you're a few miles off trail, you're probably going to have cell reception of some sort, or maybe satellite phone reception. So if that's the scenario, give as much information as you can to EMS, because they need to prepare for this case. And how an emergency room might prepare for somebody who's coming in who's completely unresponsive might be different than somebody who's actually fully responsive in AO times 4. So you want to give them enough information so they know how to respond. The other thing you want to do is vital signs, which includes generally blood pressure. We're going to play with blood pressure in person, so I'll show you a little bit about blood pressure and tell you some stuff about blood pressure, but I don't expect you to carry a blood pressure cuff and stethoscope with you as you're hiking around. So you're probably not going to do blood pressure, but you can do a couple other things that will be really helpful for you to evaluate the person's situation. It includes respiratory rate. Normal respiratory rate for an adult is about 12 to 20 breaths per minute. So put your hand on the chest for about 30 seconds. No, not for 30 seconds. Count how many times they breathe. That'll be really helpful. Then their heart rate. Same thing. Check their pulse, carotid pulse or radial pulse if they're conscious. So if they're unconscious, check here. If they're conscious, check here, and count how many beats in 15 seconds, multiply by 4. Or if it's really low, if you're counting how many beats in 15 seconds and you're up to like 6, that's a really low heart rate. You might want to go for 30 seconds to make sure you're getting an accurate heart rate. But either way, typical person heart rate should be about 60 to 100 beats per minute. I think your textbook says 50 to 100. I guess in the wilderness setting, that kind of makes sense. Typically, we use 60 to 100, but 50, 55 is not that unusual. My resting heart rate tends to be about 54 because I exercise a lot and get out, and you probably do too. That's why you're interested in wilderness medicine. So people that are in pretty good shape tend to have a lower resting heart rate. Having said that, when you have somebody passed out on the trail, they're probably not resting, so the heart rate is probably going to be somewhat higher than that. Evaluate their heart rate. Evaluate the rate, quality, and rhythm of their heart. So not just 60 beats per minute, okay, got that, but was it regular? Did the beats feel like they were coming regular? Did it skip a beat every now and then? And you'll feel that, you'll notice that. What's the strength of that heart rate? Does it feel what we call thready, meaning really light? You can barely feel it. So even you got here in the carotid and you can kind of barely feel a pulse rate. Or is it really strong and not a problem? Ideally, when you're reporting to EMS or a physician, you could tell them heart rate of 80 and it's strong, or heart rate of 80 and thready, or heart rate of 80 and irregular and thready. This really tells them something, because otherwise 80, they might say, oh, normal range, that's fine. But when you add in irregular and thready, they say, okay, normal number of beats per minute, not normal perfusion of blood. So that gives them some information. Again, check the skin, color, temperature a little bit more closely now. Initially, you did it just to get an initial sense of the person. Now you're going to look, are they pink? Are they warm? Are they dry? That's what we like. Or are they sweaty, diaphoretic, as we call it? Are they pale? That tells us a lot about the patient's condition as well. Realize that for children, heart rates change. So do pulses, but so do blood pressures, but you don't need to worry about that. You won't be taking the blood pressure of any children. But basically, with a child, a normal heart rate is going to go up higher. It would not be unusual for a child to have 105 or 110 as their pulse rate and be perfectly healthy. On the other hand, they might have something like 80. If they have 60 or 55 for a young child, if I've got a 6-year-old who has an injury and they have a heart rate of 55, that's a problem. I might want to even start CPR on that person if they're not responding. So low heart rates are really problematic, and in children, it's a sign that they might be getting worse pretty fast. So for children, respiratory rates tend to be 20 to 30, so they breathe faster than adults, and heart rates tend to be faster. Let's say 80 to 120. And I know that's a big range, but realize that for a really small infant, it might be up to 140. But for a 6-year-old, it might be about 110. And then for a 9-year-old, it might be 100 or whatever. But the younger they go, the higher the resting heart rate might be. So actually, newborns might have a resting heart rate of 160 beats per minute. And that might be, that's not, I was going to say that might be fine. Let me say, no, that's not that might be fine. That is fine. That is the heart rate you would want from a newborn. So a heart rate of 60 beats per minute in a newborn would be really problematic, actually. As they get older, their heart will slow down. So if you're checking the heart rate for a child and the heart rate ends up being a little on the higher side, or the respiratory rate's on the higher side, that's perfectly fine. Then, once you've done all that, we need to think about the communication. Ideally, you sent somebody to communicate and already get an early signal out there so that you're getting some kind of response. Maybe you've determined that this is urgent and needs a helicopter response. Maybe you're close enough to the road where you can simply get the person to the road and then call for a pickup from there, an intercept with an ambulance, for example. Maybe you need to bring them all the way back to a trailhead. Maybe you need to get them on a boat and move them for 4 hours before you get them anywhere safe. You need to make some determinations about how that needs to happen. But you need to also contact EMS or contact medical professionals and let them know the situation. And here's where we need to be calm, take a deep breath, and give them the information they need so they can properly determine what kind of urgency we have. Should they send a helicopter? Should they send a Jeep? Should they send a boat? And how to prepare for the patient once they come in. So you want to identify yourself, and that means giving them your name, but also giving them your phone number. They may or may not be able to get your phone number. Give them your phone number immediately so they can call you back if necessary. Give them a precise location. So before you call, think about this. Don't just say, I'm on the Blackhead Trail, or I'm in a boat off of Green Peak. Rather, I'm on the Blackhead Trail, 1 mile south of the cutoff for Route 33. Something like that, where they can identify specifically where you are. Explain the situation. What was the mechanism of injury? And then provide information on the victim. What's the victim's chief complaint? What's the major problem? And what things have you assessed? What are the signs and symptoms? What's the level of consciousness? Their AO ×4, or they're responsive to pain only. What life threats are they? The person had a serious bleed and now has a tourniquet on both legs. So the nature of the injury, the life threats, the level of consciousness, all of these are really going to be critical. And then go ahead and throw in a little bit of history, especially if it's really important, like patient reports that they are on the following 3 medications, or patient reports a severe allergy to whatever. That could be really important for the hospital to know ahead of time. So you want to do all of that. And then you want to work with medical control to determine the extraction method that's necessary. They're going to base all of this on your information. So you've got to make sure you give them the proper information. So that is the basics of the initial assessment of a patient. We're going to fill all that in with the information you need, obviously, on how do I deal with cardiac arrest and how do I deal with severe bleed. So at this point, you might be a little freaked out, but because you haven't learn anything about how to put on a tourniquet, and I'm talking about tourniquets. We will get to that. We're going to get to that in person, and we're going to get to that in future videos. This video is about giving you the big picture of how you're going to approach somebody and provide care for them. And then the specific mechanisms of care will fill in later and provide you with the expertise you need. Okay, so that does it for this video.